Yeah. So thank you for inviting me. And my name is Marvin Malek. Um, I'm a preceptor for the Northern New England Health Policy Internship Program and happy to join you to discuss public health. My background is I'm a medical doctor, went to medical school in Syracuse, New York, back in the Cretaceous era. And then 10 years later, after I had worked both in emergency medicine and in internal medicine, which is my primary specialty, I became interested in public health to the point where I went back to school to Harvard School of Public Health and went through a master's program in health policy at Harvard. And some other point offline, some evening, if you want to hear about that program, you can. And unfortunately, it hasn't changed as much as I might like. But during that program, I became interested not merely in the organization of healthcare services and how they're financed, but also in what I now call public health. It can also be called population health. And and that will not be the primary focus of this entire internship program. Because financing and organization of health services is more the focus. But along the way during the internship, particularly when you're comparing other countries or comparing states of the United States, you're going to hear the term public health brought up a lot. So in this talk right now, I'm going to try to give a sense of what that might mean. By the way, the rest of my professional career has largely been in primary care and also about equally divided between primary care, including serving as medical director in two community health centers and a lot of it in hospital medicine as well. So I've been on kind of both sides of the internal medicine divide. Um, so public health is defined as the science and practice of protecting the safety and improving the health of communities through education, policymaking, research on disease and injury prevention. And the key word here is communities. And who is defined as the community is very important to understanding uh, what's going to happen in the health sector. Let me give an example. In South Africa during the era of apartheid, the community often didn't really include the Bantustans, where much of the Black population lived. And so public health efforts barely reached out to those communities. And as a consequence, their mortality rates were vastly higher than, uh, than the white population. Uh, and similarly, which population you're interested in improving the health of becomes very important to to what the health of that community is likely to be like. In in this internship, when you hear the word public health used and the community is not defined by the speaker, often the community they're talking about is going to be an entire country that they may be comparing. You'll hear a lot of comparisons of the United States to other developed countries and they'll use the term public health outcomes. And in general, they're going to be talking about the entire population of that country. However, the term community can be a much narrower group. So you could say uh, there could be a report, I can give an example. I was brought up near Love Canal, which is before your time, but it was one of the first huge pollution disasters where Hooker Chemical, this is right near in Western New York where I was brought up. Hooker Chemical was just pouring toxins into the air from their into the water from their chemical factory, and literally getting into the groundwater. And it was, the soil became extremely toxic. Kids would walk in, bring it into their house. So if you wanted to study the public health impacts of Love Canal and the pollution there, If your denominator was the entire population of the United States, then you would not have a discernible impact of that pollution because it wasn't affecting people in Alaska or Florida. It was affecting people who live near Love Canal. So, and even New York State wouldn't be a good denominator. It would have to be some much smaller population, maybe not even all of Niagara Falls, New York, but the certain size geography, geographic reach around Love Canal. By the way, public, the PBS program Frontline, I think they did a whole thing on Love Canal and the history, and it's a very good example of highly effective advocacy in public health. That it was a woman who suddenly became a leader. She had never been a leader. I think she had kids, and she just was living her life. And then people in the community were developing cancer at astonishing rates. So she herself agitated, forced the politicians to become involved. And that model of a community organizing itself will often result in precipitate a public health campaign. And so when a community itself is socially uh, involved, organized, or has a sense of community and cares about each other and has social networks, you have a much more effective uh, possibility of forcing the political sector to deal with what you regard as a health issue. When uh, there was an example of the city of Philadelphia where there's some traffic. No, I'm sorry. There was on North Philadelphia is an area with a lot of violence. So a bunch of academic liberals from one of the schools of public health near there wanted to do a violence prevention program, which is actually something I've worked on in Boston when I lived in Boston. But the community said, we don't want to do that. There were basically a bunch of community leaders and they met. They felt like all these rich people are driving through a road in our community that is killing our children. There had been like 3 deaths of children on this road that a lot of people, with big cars were taken out to get to their suburbs. And it went through this very poor Black community in Philadelphia. And they said, we want you to do something about that. You need to do something about this road. And they had to organize themselves. And later in this talk, I got involved with traffic injuries while I was at Harvard, and we were that was the era of the beginning of the injury prevention segment of public health. So public health has traditionally been focused on diseases like cholera or malaria. But right around then, they began to look at injuries and divided injuries into intentional injuries, such as assault, homicide, suicide, versus unintentional injury. Like presumably most traffic deaths are not somebody running someone else down intentionally with our car, but most of them are unintentional. So drownings and most childhood poisonings are unintentional. And so this was an example of a community wanting this form of unintentional injury, pedestrian, it was specifically pedestrian traffic injuries that the community wanted to focus on. So they did a whole project. They even got some speed bumps put in, a variety of interventions, which we're going to talk about later in this talk. So there you have an example of an organized community wanting a public health project to focus on a specific health problem. Now, a key thing is to understand the difference between public health and medicine. They're strikingly different. In fact, you can argue that the doctor-patient relationship as medicine is in some ways very similar to many professional contractual relationships that an accountant or a lawyer might have with their client. The person comes into your practice, and from the day you start seeing them as a patient, you then there's an assumed sort of contract which does not get signed, but it does entail a duty to provide care. And I gotta move this thing. I can't read the second one. And at a certain standard of practice. So in other words, as a doctor, you don't have to be perfect, but you have to meet an acceptable standard, which is called the community standard. The expectation is that all of the elements of your health problems and your care will be confidential. When I say cost traditionally is not a factor from the doctor's point of view. So the doctor's not going to order a cheap test, because the doctor thinks you could afford that test. The doctor should analyze your health problem and come up with a evaluation plan that might involve lab tests and x-rays and just order them. And then, the cost factor is what a lot of this internship will be about and how things get covered. But theoretically, the doctor's analyzing the situation medically, and from their professional experience and background and their history and physical exam, they're going to develop a treatment plan with testing potentially and a preliminary treatment later on refined by the results of the testing. So either party can also exit the relationship. The doctor can say, you've no-showed for 3 different appointments just over the last 3 months. You keep calling in for appointments and not coming. That's unacceptable. We're losing money. They won't say that, but they will say that that time could have gone to another patient, which will be true. And therefore we're giving you 90 days or some period of time to find, another primary care doctor or another gastroenterologist, whatever it is. And then that relationship is then ruptured, or the patient can tell you at a certain point that they've, found a different doctor. They're leaving your practice either because they moved or they don't like you or whatever it is. And that can happen. This is not true in public health. We've already talked about how a community gets defined. And at that point, everyone in the community is in. And so every single person in Love Canal, even if they didn't care about any of that and didn't give a shit if they got cancer, like who cares? Like, no, I have to say that sentence. You got to eliminate that from the recording. Even if people in the community don't care about the problem or don't want to cooperate, they're in. And so the notion is that participation on the part of individuals in the community becomes sort of involuntary. So the children near that road in Philadelphia, that very dangerous road in Philadelphia, they didn't have to go to any office or anything. They were just in. And there were going to be activities to protect those children, whether it involved teaching them how to cross the road or, putting in speed bumps, whatever the intervention might have been. So it's pretty much involuntary participation. So again, deciding who the community is can be by request, sometimes grant funding. So this is a way that a government can influence what kinds of health problems are worked on. So let me give you an example of this. Occurred in the 1980s when HIV was breaking out across the country. People associated with the Republican Party did not want any research money or wanted very little money to go to HIV. They felt like cancer was a bigger problem. So they wanted the funding for the National Institutes of Health to focus on cancer and not HIV. So these things can become very political very quickly in defining who your community is and what kinds of problems are developing in that community, injury or illness. So availability of grant funding tends to skew what gets worked on. I can tell you that the Medicare program, with the onset of the Biden presidency, there has been in general, a much greater focus on disparities of care and focusing on the health of minority populations. It's actually has been quite dramatic and is not very well publicized. I've never seen it to this extent before in any prior presidency until Biden assumed the presidency. So there's more funding available, and the Medicare program is targeting those disparities more than ever. Has the community requested your assistance? And I gave the example of Philadelphia. And again, if the community wants to get help, things generally go better. We'll talk about that more. So now we're going to talk about an example where the community did not want the help of the trained professionally trained people who were in a position to help them. In fact, for those of you who are interested in theater, Henrik Ibsen in the late 19th century wrote a play called An Enemy of the People. And I recommend you read that to talk about how a doctor in the small Norwegian town identified that there was a contaminant, some sort of microbiologic contaminant in the water system at a local spa. And this spa was a key part of the village's economy. So when he started speaking up, saying they needed to close the spa for a period of time and clean it up, you can imagine the response of the community, because it would threaten their economy. And that dichotomy between the inconvenience of public health interventions and the freedom and economy of the population and the benefits to the economy of the population came full scope during the COVID epidemic. That people who wanted closures, to close bars, and restaurants, were vilified, and in some states, maybe Florida, the governor said nothing's going to close or whatever, and you tended to see more spread. A key thing that is very important, I don't have in slides here, is that one of the things you learn from the COVID epidemic is that when a health problem is brand new or has not previously been studied, the public health people are going to probably make mistakes. So now, in retrospect, for reasons that kind of surprised me, or the research surprised me, kids in school tend to not transmit COVID very much, and that was very much unexpected, since so many of them can be asymptomatic carriers and never become detectably ill. So that was quite a striking thing. And so what I'm getting at is that you learn more and more as the campaign, as the time goes by, and if you're organizing high quality research. And so public health research is a key element of effective high quality public health practice. Whereas nursing homes were a disaster of transmission for COVID, it turned out that schoolrooms were not. And my own suspicion is that the excretion of COVID by children may actually be less, either because their immune system works so quickly, since the immune system in human beings in mammals in general is very complicated, but it's basically kind of got several separate components, and the element called native immunity, which is not antibody or cell mediated, it works very quickly, and it is particularly effective in children. And I think the initial response to COVID was greatly affected by that wing of the human immune system. So, but they didn't know that at the beginning. And so that biology part of it, that maybe that the native immune portion, the wing of the immune system called the native immune system is better in children, that is a plausible theory, but there's two types of research in public health. One are types of studies to develop plausible theories. So you could study the native immune system of children versus elderly people, but the other thing you need to do is the epidemiologic study. And the epidemiology, what actually happens? So children may or may not have a better native immune system, but it's actually helping them. And in COVID, you needed to actually do the study. So the people who were closing schools in March of 2020, when the epidemic really hit the US, they didn't know that. They didn't know that children were not going to be spreading the COVID as much. So you you need to forgive that error. Fauci made a mistake in March of 2020 when he said that masks are not useful. There is some plausibility or biological theory why for certain types of respiratory illnesses that masks would not help. But in many cases, masks do help. And the quality of the mask, whether it's an N95 or a KN95 or just a regular surgical mask or just a bandana or whatever, these all turned out to have variable levels of effectiveness. And after that got studied, at that point, Fauci can make a better recommendation. His mistake was to say people shouldn't wear masks. That was a mistake. He could say, we need to save the highest quality masks for the medical people, or people are not going to be treated. That he could have said, or he could have said, we simply don't know yet. We have the expectation that they won't help, but that's based on theory. We have not tested it. It's the epidemiology where becomes the gold standard. You need to know what actually happens. This is true in medicine as well, that you can have a theory that some drug ought to work, but this has been happening lately with Alzheimer's, where they come up with drugs that seem to reduce the number of these, plaques, tau plaques. But when they actually give the drug that seems to help with that, what actually happens? Is there any population of elderly people or people with a family history of Alzheimer's? Does it actually help? So you need a control group, and so you need what's called a randomized controlled trial, ideally to decide on a pharmacologic treatment. And we're going to talk about that in the last portion of the internship about pharmaceutical research. Anyway, so the gold standard is learning what actually happens, and you have to have high quality studies. So early in the pandemic, they should have been qualifying a lot of the recommendations. And at least in the case of masking, Fauci made a mistake. It didn't last long, but he got in big trouble because all of the closures and the closing everything down, like what happened in China for so long, it was just generating so much hatred of public health. So by the end of the pandemic, across the country, and not just at the federal level, but at state and local levels, public health departments have been decimated. There've been so much unpopularity to public health that there's staff shortages and even little local health departments, in states across the country. It's become a huge crisis as fallout from the pandemic and the public response to it. So again, the case of COVID, the medical doctors treating COVID, well, even prevention, the preventive part of it, like you've heard all this about Paxlovid, which is getting heavily publicized on television. It's a combination of two antivirals. It's barely effective. It's like minimally effective. It only works in people who are never had COVID before and who never gotten a vaccine. So, it's barely effective medication. And on the other hand, if you take all the public health measures together, particularly vaccination, here they are, physical distance, building ventilation has been underemphasized all along. It's great reductions. And the other thing is, when people go to the doctor with strep throat, their expectation is 100% chance of cure. And people understand that if they have certain illnesses like cancer, they may well not have 100% chance of cure. But in public health, it's very rare that you have 100% perfect intervention. So building ventilation, number 3 on this list, it's not going to be 100% effective, but it's like damn effective. Maybe 50, 60, 80% effective if you have a building that's well ventilated. So they did things, moving events outdoors, closing bars and restaurants, so all this kind of stuff. Vaccination turned out to be very useful. On the other hand, you could argue that it was very disappointing because some vaccinations prevent you from spreading the illness, and COVID vaccination didn't do that. So that was disappointing. It mostly prevented you from dying and from becoming quite ill. It was effective at that. So, and unfortunately, what that meant was there's not as much herd immunity as you'd like. Herd immunity is when enough people in a community are themselves immune to the disease. When you're getting to 70, 80, 90% of a population, that the disease will have more trouble spreading as when everyone is in the whole community is susceptible. So uh, with measles vaccine, it's a terrible disease, about 1 in 1,000 mortality overall. Uh, but it's a tough one. And now that there's this anti-MMR vaccine activism from both the political segments of the left and the right in this country, it's a real problem because 1 in 1,000 likelihood of dying doesn't seem that bad, but actually it's terrible. Like I do prescribe drugs that have 1 in 1,000,000 death rate. I don't prescribe drugs that have 1 in 1,000 death rate. So even little numbers like that can make a really big difference. And measles is bad enough to justify vaccination. So, and it's a good enough vaccine so that it can prevent you from, substantially prevent spread. So, and then public relations efforts, and none of this went very well during the COVID era. Uh, so anyway, so even though the medical intervention, so for example, I took care of a patient who, with COVID, who got a lot worse through no fault of our own, because as I said, the medicines don't work very well. And she ultimately died. And yet everyone involved was like very appreciative of our effort. They had appropriate expectations that she had a lot of risk factors and she didn't make it, and you know, so on the other hand, there were probably millions of people in the country who never got COVID because of public health measures. And do you think that even one of them went down to the health department or emailed a thank you note? I was the one in the community who would have, I was one of the 10,000 people in this city who would have died, but didn't because of all your public health measures. So thank you so much. That never happens. Nobody, if I'm campaigning about love canal or something. Nobody ever says thank you to public health people. It's incredibly rare. In fact, they hate them. This is often the case. As you saw with COVID, Fauci, a third of the country thinks Fauci should be like, tarred and feathered. It's like this is how it goes. So the community often is an unwilling, angry patient, even if their lives might have been saved. So now I'm going to talk about the importance of public health. And there have been a lot of studies about what types of interventions or what portion of the improvement in mortality in the United States is due to public health measures such as sanitation, separating out wastewater from good water, safe from ventilating buildings properly, public health type measures, versus what percent are due to poverty and social disadvantage, versus what percentage of a country or a community's mortality is due to bad behavior. You're a smoker, you died of lung cancer, you brought it on yourself. So that's an example of sort of blaming somebody for the bad behavior, bad health related behavior. So when you look at that, and a lot of propaganda from anti-public health people often will exaggerate the impact of behavior to oppose both public health measures, to oppose anti-poverty programs, and to oppose uh, uh, a national health program, like single payer universal health care, where we're all paying in. We all pay in a single payer system. Everybody pays taxes to give everyone else health care that's affordable. And if you're of the mentality that you caused your own illness because you don't exercise, you're lazy, you're fat, you smoke, you smoke, uh, you could then take the next logical step and say, therefore, I'll pay for my own care, but I don't want to pay for anybody else's because they're just a bunch of smokers or lazy people, whatever. And so there's a certain portion of that behavior does matter, and and the various percentages really matter. Now, by the way, these various guesses are often what are called social determinants of health, like poverty, homelessness, um, are usually come in around 40 or so percent of importance, and behavior maybe 30 or 40, and then healthcare as little as 5, but as much as 20. And I want to just make a comment that those data partly depend on the time frame that your study is using. So if you're going to start the time frame at the year 1700 or during the era of the Black Death, then social determinants are going to, and public health measures are going to become very, very, very important, whereas behavior and medical care are going to really look unimportant. So when people were dying before age 5 of diarrheal illness and getting cholera, you're, back when that was common, then the social determinants of health are going to probably be as much as 80 or 90% importance. And on the other hand, if you're starting the study from how much of the improvement, like we had a decade in the United States, the 1990s, when was the one decade when there were very substantial medical advances, pretty much confined to cardiovascular medicine. These range from interventional cardiology, like coronary stenting, to cholesterol medications, which, another one of these deals where a highly effective intervention like cholesterol medication has had this terrible popularity. It's like, there's all kinds of conspiracy theories. It comes in second place after vaccination for the most pharmacologically related conspiracy theories. But anyway, these interventions for both primary prevention and secondary prevention were highly effective, and you saw mortality rates in the United States improve. However, during that same period, there was actually a big improvement in smoking behavior related to both exercise and smoking. So they had to tease that out, and during that decade, it was both. And probably the behavior won out over the medical part of it. But that was the one decade when medical improvements really helped a lot. Another caveat on this is that the key function of primary care, as opposed to all the other specialties combined, was really critical because so many public health interventions come out of primary care offices. You think, vaccination, lead screening for pediatricians do lead screening to see what children's lead levels are if they live in, a lot of urban areas where there's a lot of older housing. So, and also, do you even say that banning lead from paint, like you would call that a social policy, a political or social policy that prevented all the complications of lead poisoning? But anyway, it occurs nowadays. It's primarily that we banned it decades ago. It's primarily occurring in primary care offices where pediatricians are screening for lead toxicity. and addressing it appropriately. So, how are you going to fit that into this kind of paradigm? Are you going to call that a medical thing versus a social thing, cause versus behavior? Is the patient going to cooperate with whatever you recommended to do about the child's elevated lead level? So, they kind of mix together, and a lot of it, if you credited primary care for all that primary care offers to public health, the estimate would not be 5%, it would go up a lot because so many public health interventions are done in primary care offices. So that's another thing. Uh, and by the way, so another study, we have sessions on disparities in care, but there's been increasing numbers of studies demonstrating that other social determinants of public health that were previously thought to be primarily behavioral may be social. So there's a growing body of research showing that growing up Black in the United States is harmful to your health. And many diseases seem to develop, and people can stop smoking and and eat granola or eat healthy food, but they're not going to turn white. So it's so this teasing out social determinants of health versus individually or oriented in behavior, and again what occurs medically, they're kind of mixed up is what I'm getting. And uh, most people believe that social determinants of health writ large are a huge part of it, but I would not want to understate the importance of primary care in contributing to the public health effort. So we talk about three forms of prevention. One is primary prevention, which is where you take a vaccine that prevents the disease from developing at all, like measles vaccine or polio. Or you take COVID vaccine and you're kind of preventing the disease from becoming real bad. So primary prevention, so obviously measles vaccine and polio are giving you primary prevention. COVID could give you primary prevention if it meant the difference between asymptomatic carriage of the virus, where you never develop a single symptom at all because you got the vaccine, and becoming ill. And in that case, you would call it primary prevention, but you could say it's secondary prevention because you did become ill with COVID after you got vaccinated, but you would have died if you hadn't gotten vaccine, and now you're just going to feel, you know, bad for a few days. So you could kind of call that secondary prevention or mitigating disease severity in that case. In the case of the cholesterol medicines, they're primarily effective for secondary prevention. If you give every single person who's over the age of, say, 55 cholesterol medicine, you're not seeing much benefit to the population. But once you're declaring yourself as having active coronary disease, in that population, it's effective. So it's a very good drug for secondary prevention. Tertiary prevention would be giving rehab therapy to somebody who has a stroke, where you can, or spinal cord injury. You can make them greatly enhance their lives, even though you neither prevented or mitigated the severity of the disease. You just kind of got them going. So you think of those three types of prevention. So what would you call this one? You know what this is? It's a
That looks
truck. It's a big truck, by the way. So what's this little bar on the bottom? You know about that? That bar is put there after a public health campaign. The Institute for Highway Safety studied uh, cars that, so let's say the truck stops and the truck's brake lights are broken, or a car is speeding behind a truck. The truck's going 30 miles an hour on an interstate because there's some problem on the road, and the car behind is going 78 miles per hour and crashes directly into the truck. So without that bar, the car, a small car, literally goes underneath the truck, breaking the glass in the windshield, leading to very severe injuries. Whereas that bar prevents the car from doing that. So instead, the car crashes into the truck, and there's still a lot of injuries, but their severity is lessened. So whether you want to call that primary, secondary, tertiary, we'll get into that in just a second. So this is the classic, this is called the Haddon matrix. And Haddon used this for analyzing vehicular disease. So, sorry. So you could have, and the Haddon matrix is divided, it's a 3x3 grid, an intervention directed before the event. So that would be like measles vaccine, say. If you give measles vaccine 2 days after the patient becomes ill with measles, it's not going to work. So it's a pre-event intervention. Similar, a driver training course would be a pre-event. You can't start driver education while the person's crashing into something. So, but you could do a drunk driver public health intervention, on the TV. Then there were, for drunk driving, they had legal things where you got in a whole lot of trouble if you were caught driving, and you have cops on the road who are stopping you and checking to see if you're drunk. Like on July 4th or on New Year's night, sometimes they'll stop everybody on the road and check their alcohol level, that kind of thing. So that's kind of a pre-event thing, but you could call it um, an environmental intervention. The social environment created legal um, sanctions against people who drive drunk. So that's a pre-event environmental intervention. And anyway, so the vehicle could be modified. So the car could have an airbag, and that's a vehicle intervention so that the crash is happening, and that one we call an intra-event intervention. The airbag in your car in the vehicle gets deployed, and it keeps you from having such bad injuries. And also vehicles now crumple in a different way rather than it used to be the steering wheel was rigid and it would, crash into your chest and cause all kinds of thoracic injuries. But the vehicle crumple zone kind of prevents that. And, obviously there's still a lot of deaths, but it prevented some of them. So that's an intra-event vehicle intervention. But you could argue that it was pre-event because a whole bunch of public health people did a campaign and they forced these vehicle crumple zones, and then they had to force the car companies to use them. So in that sense, it was pre-event. So what I'm getting at is that there's all kinds of ambiguities in trying to come up with what to put in each thing. But the nice thing about the Haddon matrix is that it forces you to think things through. So in other words, um, let's look at malaria for a second. So the host is the patient, and they've been struggling to find an effective malaria vaccine, and now they have one that's up to preventing 30% of the deaths. Well, that doesn't sound good, but 2 million people die of malaria every year, so that would prevent 600,000 deaths. In that sense, it doesn't sound so bad. So, this is kind of how it is with public health. Do the best you can with what you got. And anyway, so that's a pre-event thing. So what are you going to call the vehicle for malaria? And there's two answers, and they're both correct. So you tell me what you think they might be.
The mosquito.
I can't hear you.
I just said the mosquito.
Yes, you could say the mosquito's the vector. That damn little thing is flying around, and it's injecting malaria, protozoa into me. And so we could do a bunch of mosquito intervention. You could drain wetlands, which isn't good for the environment, but it's good at preventing malaria. You could make all the male mosquitoes infertile so they can't breed as effectively. Um, anyway, so you could do mosquito-directed things, interventions. You would spray DDT. That was wondrously effective at preventing, uh, you know, millions of cases of malaria. It wasn't very good for the avian population. So anyway, but that's another type of intervention directed at the mosquitoes. Does anybody come up with the other correct answer about
You could do like pre-exposure prophylaxis for at-risk populations.
pre-exposure? You could in other words, vaccinate people or tell them to use
So,
mosquito netting at night. What do
well,
you,
that's what I feel like I believe there's like a medication like you can take. Um,
oh, you mean like travelers do,
well,
like taking
travelers, but like
chloroquine.
if it's like endemic, for instance, I believe there was a pre-exposure prophylaxis medication, but
There
I
is.
could be wrong.
Yeah, chloroquine or mefloquine, or now there's a few other regimens. For travelers who are going to have a limited stay, like less than 6 months, you
Okay.
take a weekly dose of chloroquine, which is also a treatment of malaria in a different, I'm sorry, in a different protocol where you take it 3 days in a row. But you
Mhm.
can take one dose a week and you're much, much less likely to get malaria if you go to a country where all the malaria is chloroquine sensitive. So that's a intervention to that's sort of directed at the host, but the other vehicle I was getting at for the second column there, what's the agent of malaria? What's giving you the disease?
Are you
Mosquitoes
talking
injecting it, but what is it?
parasite?
The
Plasmodium?
plasmodium. The
Um,
plasmodium organism is
Yeah.
getting injected in your body, and that's what's generating, so COVID virus is, the sort of agent that's giving you COVID. And so, in the case of malaria, so the environment, I think I have a slide. Yeah, so the environment is particularly complicated to define. So it could be the physical environment. You could have poorly maintained roads or a high speed limit. You could put in a speed bump to slow the traffic down and say there, in 100 yards, there's going to be a speed bump. And so you damn well better slow down, so you don't crash into our children. Um, anyway, so the legal environment is to have drunk driver laws, um, vehicle inspections, lower the speed limit. The social environment, you can have a designated driver program where there's a whole public relation thing. Don't drink, come up with a designated driver. An economic environment would be funding road safety interventions. I mean, the best intervention for reducing the number of traffic related injuries is to create an effective public transit system. And that intervention prevents traffic deaths. It's infinitely better for climate change and the environment, and it's also faster. Commute times in the United States have been getting worse now since I think 1990 because we don't have public transit in the US. So public transit is an example of a synergy. No, I don't know what the word is, but when a single intervention has unrelated benefits, and there are many interventions in public health actually have that effect where there's multiple benefits to a certain intervention. Other public health measures have economic costs. So when China closed down for such a long period of time with COVID, it had an economic cost for that country. If you do put a speed bump in, that all the people who could have gotten their day done faster and they're just say they're a delivery person and they're slowed down by speed bumps, so they're going to get less work done, and so it makes their work less efficient. So public health interventions can have economic costs, or in the case of public transit, it's looks to me like it's primarily benefits. But anyway, So anyway, though, so there's several types of environments. And if you want to go through a Haddon matrix, one other thing I wanted to say is, well, let's go back to the traffic one. When you're looking at a health problem, you might your analysis might benefit from dividing the problem into components. So if you wanted to prevent injuries from falls, you could have, I don't know, one intervention directed toward younger people who do risky things. I don't know, to try to get them to stop, jumping off of diving into something where there's no water, and they're killing themselves. We actually have an example of that in Vermont, where there's a place where people go diving and there's not enough deep enough water down there, so there have been deaths. Anyway, or you can say, well, falls are primarily among the elderly, where people die of them, hip fractures. So you could have intervention that way. But anyway, so divide up the scope of a problem. So in the case of traffic, you could say, well, pedestrian injury prevention is probably different from injuries to people in the car. And that turns out to be true. So public transit is amazingly effective for preventing pedestrian injuries, even more than driver injuries, since they're more of, public transit is more of an urban intervention. So huge numbers of pedestrians are not killed when you have public transit. Compare, let's say, Los Angeles to New York City. Anyway, or you could say bicycle injuries to bicyclists. How is that part of the deal? Or you could say rural injuries versus urban. So in other words, you break down a problem into a component and then look at the epidemiology and do a Haddon matrix for each one of those separately. So let's go through one of them I'm going to let you guys talk a little. This will be the end of the talk. We'll go through a Haddon matrix if you wanted to do a violence prevention project. So first question is, do you want to divide the problem of intentional injuries due to people hurting each other, violence? Can you think of how you might divide the problem up? Either agent-wise or into types of violence? Like how might you go at this problem? Say homicide in particular.
I think the agent, a lot of it would be the weapon of violence.
Okay, so here you can go into the middle column, and look at the agent. So you're thinking probably that gunshot wounds are more lethal than knife wounds, and knife wounds are more lethal than blunt trauma, say with a baton or a bat or something. Is that you're thinking about the agent?
Yeah, I was also thinking like if you could do like pre-event, event, and post-event, it would be
Okay,
um like location, maybe prevent like access to weapons, these kinds of things.
okay. So you're going to do an intervention in the legal environment to keep people from buying them or force them somehow to store them, or how would you do it legally?
I think so. Like impose restrictions on like ways to access these weapons, like make it harder to access them potentially. And
You mean
then
not buy them in the first place, or do something with them after they buy them?
I feel like before buying them, I would think about like how as policies and like the infrastructure, how easy it is to to kind of change the access we have to these weapons.
Do you feel like maybe we should have gun control?
Yeah.
Like maybe they shouldn't sell military weapons?
Yeah.
Yeah, well, a lot of people believe that, and a lot of people don't. But I it's a it can work. Now look at the limitation of that intervention. So this country has more firearms than there are people. And if a gun has a life of 20 years, how if you were in a public health campaign promoting gun control, and you have all these people, sort of Second Amendment people. Now, notice this is getting political right away, by the way, as public health campaigns often do. But one of the important things that I mentioned in the case of Fauci is to not overstate the benefit of an intervention. So personally, I believe that if we suddenly had British or Japanese level gun control laws, that we would have an amazing benefit to the public health take place in about 40 years, or 20 or 30 or 40 years. And the benefits over that period of time would be gradual as one weapon after another went out of service. When gun control laws are about to be enacted, there's a paradoxical effect where people start buying more. So every time a Democrat wins the presidential election or takes over Congress, first thing that happens before they can enact any legislation is a whole lot of people buy guns because they fear that the Democrats are going to do gun control legislation. So when you're enacting public health laws, you have to always take into consideration adverse effects. Let me give you one example in the traffic area. When you repair a road that has huge potholes, then people start driving a whole lot faster. So a repaired road won't necessarily lead to fewer injuries. There's something called risk homeostasis, where people seek a certain level of risk, and the better you repair a road, and the more they feel they can control their car, then they go faster, and all the benefits from repairing the road kind of go away because people's behavior may overcome the benefit of the intervention. So unexpected, harmful, adverse behavioral consequences sometimes happen with public health intervention. However, I'm with you. I personally am a big believer in gun control because I think over a period of, a lot of years that it would gradually help, but there are issues. And I think you have to give the public a realistic expectation of what to expect. I think when people found that the COVID vaccine didn't prevent the illness, that was a real setback because some public health people had sort of promised that it would, when all it really did was prevent more serious illness. Anyway, so you have now divided up the problem into gun versus other vectors. So you're not taking baseball bats off the street. You really want to take guns off. And I support that. Guns are way more lethal than forms of blunt trauma. In fact, guns are way more lethal than knife wounds. I worked in the trauma unit at Cook County Hospital where I did my residency training. And gunshot wounds are like in a whole separate category. Knife wounds is kind of play with it. And because knives often miss things like the aorta. Like the aorta is kind of slippery. You stab somebody in the aorta and you got to really like impale it. Because if you hit the side of the aorta in a stab wound, your knife's probably going to slip off unless you stabbed them really quickly and got the aorta straight on. So a gunshot wound just goes straight through everything. So they're way more lethal. And I support your idea of, if you're talking about homicide, of certainly as opposed to assault or fighting behavior. For homicide, I think firearms are a real good way to, to focus on an intervention. How might you divide up the problem? Anyone have any ideas? Like who gets murdered?
Yeah, I was thinking it might be interesting to look at the environmental social component and talk about like the necessity and prevalence of gang associations in different areas and neighborhoods and how that can facilitate violence and deaths in communities.
Right. So you want to go after the gang issue because there are a lot of those homicides
Yeah, I think that would
and
be an
gunshot wounds.
interesting way to look at it. Yeah.
Yeah. So that gets mushed together with illegal drug-related violence is tied up heavily with gangs. So that's sort of been in a category two, is gang and drug-related violence. So in other words, you could look at drug treatment programs by themselves potentially might prevent violence. Or other types of gang-related interventions. What might work to deter people from joining gangs?
Yeah, I can't say I'm an expert on it, but from what I've seen, different like some social community support networks to just kind of engage youth in other ways and create other more secure attachments within the larger community, and like mentorship programs as being different interventions that have been used in various communities, but I can't speak to the effectiveness that they've seen so far in those.
Right. So yeah, you can look at, I mean, when I think of preventing gang violence, I sort of see it on two types of environmental interventions. One is economic inequality generally. You know, the huge polarization of the worsening of income inequality in the United States and in fact worldwide over the last 40 years since 1980 has led to poverty. So joining a gang is also a way to have, for many members, it gives them greater power in the community and greater more money. They may be getting more money out of selling drugs, being part of a gang. So economic inequality may be a part of it. Also, uh, having safe recreational opportunities. So you may have heard that of a movement called the environmental justice movement, where polluting factories or interstates, highways with all their pollution tend to go through poor areas rather than rich areas. Okay, so that's those kinds of things, pollution in poor communities has been the focus of environmental injustice. But I think I think there's another form of environmental injustice that's kind of a what isn't there as opposed to what is there. And when I ask the question of what isn't there, and what there often isn't, are safe places for recreation. So is there a park where kids can play and where maybe there's a supervised, do you have a community that has supervised after school programs? Just a place for kids to blow off some steam, and get some exercise. And having a safe place to exercise and to recreate for children and teenagers, it's not going to solve the whole problem of gangs, but it helps and it's an intervention. And many poor communities have like no good parks, no safe place to play and to, I don't know, whatever, play, basketball or whatever they want to do, baseball, I don't know, and get out there and be a child and be an adolescent and a teenager, so create a society where raising children is part of a community effort in supporting families when they're raising children, and maybe that'll help. Any other ideas?
I have an idea, but it kind of involves both the pre-event and the post-event.
Mhm.
So I think it's somewhere around or somewhere above 50% of people who were previously arrested and served prison time go back to prison after, I believe, 3 years. And there's I read about it a couple of days ago. There's this crisis going on in America and the United States where a lot of our prison systems do not treat inmates as well as they possibly could. And there have been actually several prisons that have been closed down because of the violence that has occurred to these inmates. It's almost a reflection of the Stanford prison experiment. But I think if there was a way we could develop a system that puts inmates in a position where they can go back to society in a way that will be successful for them and that will allow them to live within society, would be better than what the current system is and like the current programs are, which don't necessarily prepare them to be reintroduced to society.
Okay, so Kyle, you can volunteer to introduce Fred Rotnick on July 1st, and he will give a talk on that topic and has much more useful to say about it than I do. But yeah, that's a great intervention. That's a great intervention. Where, if you live in a country where prisons are a hotbed for, more gang proliferation and, learning that, antisocial behavior or criminal behavior from each other, and are not transition, there's no useful effective transition back into, a more productive role in society, then yeah, it's a very important intervention. So any other ideas?
I have one. And I think I was gonna say something more about like host, which would be like victims in the scenarios. So in my situation, I might end up taking like women or children because they are kind of like less powerful and get like more easily harmed in this kind of situations. So for the pre-event, I was suggesting something like training for de-escalating like violent situations or like self-defense training that can help these population. For event, I might say like giving them the knowledge and resources to have equipments in hand, which might come handy in like situations like this where they can use it for their self-defense. And for post-intervention, something like a support group where they can like talk about whatever happened to them and kind of like deal with it and cope with the situation.
Yeah, so violence educational programs. There have been programs to teach children between 3 and 8 years old how to safely cross the street, look both ways before you cross the street. You can do violence, conflict resolution education. So especially people with children with low self-esteem, if you take something away from them, they have no way to resolve the conflict. All they can think of do is hitting the other person. And so one of the strategies in conflict resolution is to make a joke out of it rather than hitting the person. Like, okay, you just took the baseball away from me. I was about to use it, but I really want you to use it because I think you'll have more fun than I will. Like, just say some stupid comment so that you don't feel like you're losing face. Like, just ideas about how to resolve conflict in a constructive way. And a lot of the violence education stuff is about conflict resolution. But I just want to say 2 more things about this because I actually have a couple more slides. I just want to quickly go through. In that right lower corner, post-event environmental interventions, where it says emergency medical system and trauma networks. So this is after the injuries occurred. Say somebody got stabbed, at the corner of 3rd Street and, 4th Avenue or something. How quickly can the trauma system get this person to where they need to go? If their stomach was stabbed or something and they need to go to the operating room, how quickly can you get them to the emergency department? How quickly can the emergency department get them to the operating room? The effectiveness of a trauma system. And just to give an example of this, in World War II, if you got a penetrating injury from an explosive, a mine, or a gun, gunshot wound, shrapnel, your likelihood of dying was 33%. And in the Vietnam War, it went down to 25% because they improved the trauma system. By the Persian Gulf Wars and the Middle East Wars, it's now down to 9% death rate. And what that has meant is that extra 26% of people who are not dying anymore, many of them are living with not just psychic trauma, PTSD, they're also living with amputations and permanent injuries so it's been a a lot of people, more people now are living with disabilities because of the effectiveness in the golden hour of trauma, of getting people to a trauma center within an hour of serious trauma. So the healthcare system fits in that lower right corner. But if you're in primary care and you have effective ways to engage the community and create, better education, conflict resolution, if you live in a community with a lot of violence, you could say that primary care could be in the left upper corner where you're doing education for the community and trying to educate people. So there would, by the way, there was another angle of homicide and violence you didn't mention, which is the part, mostly men killing women, their girlfriend, blowing away their girlfriend when she does something they don't like, just partner. It's got a good name, but I'm not thinking of partner related violence. So that's a big source of homicide and intentional injury in the U.S. So I'm going to take one more second just to go through. So in the 1950s, there was tremendous promotion of smoking. It became sexy. They got doctors to promote smoking. The sexiest women. They even went after black people, and they didn't smoke enough to make the tobacco companies happy. We began to see, what this white thing is in the upper lung? That's a huge cancer, typical location for a lung cancer. And more cancers are developing by the 50s. So what strategies were used to deter all this? A landmark report came out in 1964 by the Surgeon General of the United States saying how all these kinds of diseases that tobacco caused and how terrible it was, all that. Summarizing some of the medical literature, there was a multifaceted educational campaign, TV ads, brochures in public places, signs put up saying, quit smoking, don't start smoking, TV spots, and I'll show you the radical neck lady a little later. Ban on tobacco advertising to ever greater extents, take it off billboards, TV, radio. Taxation was a great strategy. You could even tax gun purchases more heavily. One problem with taxation is things will go to the Indian reservation or across to a border to a different state where the taxes are lower. So that's a problem with limitation of taxation, but it really helps. Taxes tend to deter young people more than older people in general. So they're good for prevention of tobacco smoking among teenagers. Taxes are pretty good. Bans on smoking on airplanes and indoors and, entire facilities. What's the last one? And then get doctors to talk about it. So here's a statistic. If a doctor tells a smoker, patient of theirs, to quit smoking, anybody guess what the likelihood of them quitting is? Single doctor visit, the doctor says, quit smoking.
10%?
I didn't hear you. It's louder.
Sorry, 10%.
Well, you're very close. We're going to stop it right there. That's so close. It's 7%. Now, you would say, well, why did you've been living in a country where there's all these anti-tobacco stuff. Why did you need to hear it from me? Like you, 7% of the population. Somehow it helps. If a nurse says it and the doctor both says it, that's even better. So, and then they started developing drugs that help to people to quit. But yeah, 7% of people will actually quit. Single doctor mentioned. So you should say it. Don't condemn people who smoke. Just say, this is our primary care visit. We have one a year or something, or, if you're healthy, but you smoke. It's really pretty bad for your health. It would be great if you quit. Would you like me to help you? That's it. And if they say no, I go on to the next topic because there's tremendous pressure on primary care to get through their visit, and you can't spend that much time on somebody who's not going to quit. So here's some of the ads. Look at the radical neck lady on the right lower corner. She's terrible. Young people don't want to look like that, so she might help people to quit. And then having tobacco come out of your ears. Anyway, and here's the guy in the upper left corner. He doesn't like having to be on oxygen for 5 years before he dies of COPD, so he looks pretty unhappy. Anyway, the lethality of it, putting them with guns. Anyway, so here's a multifaceted campaign, and here are the data. They didn't get to zero in terms of tobacco shipments. And teenagers, they had a relapse in the 1990s. the whole period when very focused on obesity, because teenage female smokers are a little thinner than the ones who don't. But anyway, but they kept up the public health campaign and the kids caught on, and so 12th graders are less likely to smoke than ever. This is the final one. This is the overall population prevalence of smoking. So they got from 43% of the population smoking down to 22, 21 by 2015 or something like that. 2000, I don't know, whatever it is, 2006. Anyway, it was, again, in public health, you don't get to 100% perfect, but they got about half the people in the country to quit smoking. And so that was good. But that's not perfect. So we have a ways to go. We keep working at it. And you saw a multifaceted campaign with multiple types of interventions, doctors getting involved, the public legal environment with taxes and prohibitions. So this is how a public health campaign goes. And the more multifaceted it is, the more successful it's like to be. I've gone over the time limit. I'm really sorry about that. And in terms of your individual projects, I think we already talked about enough of that. So any questions, or can we adjourn? What do you think? Okay, sorry we went over, and have a nice afternoon. I'll see you all on Thursday.